Hello, everybody. Welcome to our Uveitis support group and educational seminar. Some of you may have watched the video for patient advocacy. My talk was on the role of insurance and prior authorizations and appeals for rare diseases, and Dr. Anesi on advocating for yourself. And tonight we have a guest. We're privileged to have the guest involved with us from Horizon Pharmaceuticals, and that's Veronica Moore. Veronica has a bachelor's from East Carolina University in public health, and she holds a master's degree as well. She comes from us with over 13 years of combined experience in the rare disease arena, spanning from patient advocacy, patient engagement, health equity, and public health education, patient recruitment and retention. And she serves as the Senior Patient Advocacy Manager. Sorry, Saint. I uplifted you. Okay. As the Senior Patient Advocacy Manager for Horizon Pharmaceuticals Therapeutics. In this role, she is responsible for developing mutually beneficial relationships with patient organizations in the area of thyroid eye disease. Thyroid eye disease, I'm not sure how many of you here have that, but it's a serious, progressive, and vision-threatening rare autoimmune disease. And Horizon developed the first medication to treat that. And her efforts are to support the patient's journey as it relates to their thyroid eye disease. She is a key contributor to the health equity, inclusion engagement, and planning at Horizon Therapeutics as well. And so welcome, Veronica.
Thank you so much, Frances. I'm really honored to be here. Horizon Therapeutics is honored to serve as a sponsor for today's conversation about advocacy and navigating the healthcare system. As many of you may know, Horizon is a biotech company focused on delivery, development, and commercialization of medicines that address critical needs for patients impacted by rare, autoimmune, and severe inflammatory diseases. We understand the tremendous value of empowering patients, which is why we also focus on disease education and self-advocacy that enables patients to have open dialogue with their healthcare providers and ultimately a role in the shared decision-making regarding diagnosis and treatment options. Many of us at Horizon know a patient, are a patient, or have been deeply moved through the action of patient stories. This deep appreciation fuels every decision we make and shapes who we are. From the medicines we develop to the communities that we support, for us, it is personal. I also know this topic today really resonates personally with those attending the call today. So without further ado, I'll pass it back over to Frances to jump right in to today's session. Thank you so much.
Thank you, Veronica. So this evening, we're going to have an open session discussion. We ask that you keep your mics muted until you're ready to speak. You can raise your hand. You can ask a question in the question log. And Dr. Anesi and I and Veronica will be here to answer your questions. So basically what we're focusing the talk on tonight is you have a rare disease, whether that's uveitis or thyroid eye disease or another ocular inflammatory disease. We're called orphan diseases. There's not many of us that have these diseases given the entire population, which is how they classify an orphan disease. And so there's not much research and development that goes into orphan diseases, or at least there wasn't until recently when more money was being invested in trying to help orphan diseases. But as drugs come to market, like Tepezza and Humira for uveitis with FDA approval, insurance companies don't just go ahead and accept that prescription from the doctor. They now set requirements for you to get the FDA approved drug, which in my opinion is unethical, but that's the way it goes. And so myself and people like Veronica and the doctor like Dr. Anesi, we become advocates for you to try to get what's needed and what's right for your care. So my talk was about basically how we work that end for you as we basically become your advocate. We're basically writing to have, excuse me for one moment, I have to just, I'm having something going on at the house. So sorry, that's what happens with Zoom. Dr. Anesi, can you take over for a minute for me?
Sure. I wanted to add to something that Francis was talking about as far as difficulty getting things approved. One more hurdle I see coming up in the next 4 or 5 years as being a big problem for some of the drugs that have been around a little while is the biosimilar market. And insurance companies are increasingly more engaged in trying to save a few $100 or whatever it is to get people to use medications which have been shown to have similar efficacy to the drugs that had been around before, that look very much like those drugs that in some disease conditions have produced similar results, but not necessarily proven to be the same, especially not in eye disease. And we've found that a lot of those patients who are on or have been forced to switch to those biosimilars have had worse courses, at least in our experience. And that's been a really, really big hurdle. So that's one other thing we've been sort of fighting against.
Yes, I agree with that. That's been the latest this year is the biosimilars. But part of the problem with that is the biosimilars that are at now, those drugs aren't FDA approved. So Remicade, for instance. But the insurance companies put up obstacles and even for FDA approved drugs. So that's where we become the advocates. And you have to become an advocate for yourself as well. But we write very strong letters of medical necessity to get these drugs approved. We have to show, failure of other medications to get them approved. And so I think as the patient, it's good to be educated on that. So you too also can be part of that appeal process and advocate for yourself, as well as advocate with other doctors, like Dr. Anesi spoke about in his talk. Advocate for yourself to other doctors who maybe don't have the knowledge to prescribe these medications, and just sort of stick with the conventional steroids. So we'd like to open up the discussion now, and part of our support group rules are to help each other. We don't criticize. We may come from different, past experiences, but we're trying to help each other move forward and conquer the issues that arise when having a chronic illness, and not only that, but a rare disease chronic illness.
There's a question in the chat asked by Lissa that what are the biosimilars namely? There's actually almost a few biosimilars for almost every single biologic out there, except for Tepezza, which is very new.
And Humira.
At least I don't know, and I think there's one for Humira too. There's definitely some for like rituximab and Remicade and Fliximab, and
Humira one is not on the market for another couple of years. So.
Oh, okay. So I mean, they're coming out all over the place. You'll see them a lot. I have a feeling it's going to be a really big point of contention for a lot of people who treat all sorts of inflammatory diseases. I think like the next 5 years, I think that's our major uphill battle, unfortunately. And like I said, I don't think Tepezza being so new, will have one probably for a while if it does at all. And it's been sort of a, I give them a bit of a plug. I wanted to say something about them. It's thyroid eye disease is one of the sort of unsung real bad problems in orbital inflammation. And it's often treated actually by plastics professionals, oculoplastic doctors, or neuro-ophthalmologists, people who don't necessarily deal with the eye because it affects more the orbit, but indirectly then affects the eye. And it's very tough to treat. These patients often get, despite the best and most swift efforts to treat them, problems with their eyes that are not only functional, but cosmetic. They affect them for the rest of their life. And this medication has been able to do a very good job in helping to treat these patients, almost reverse those problems to a degree that's never been done before, which is great. It's just one of the things that's out there. So if you know anybody with thyroid eye disease, I would strongly consider they inquire about this medication, especially if it's acute and it's starting to get worse, because that's the growing rate. I have a couple people who are sort of in line for it. I think actually my first guy got his first dose yesterday or today. I can't remember. Maybe it was today. Yeah. And I'm excited to see how it works for them. But I have a lot of other doctors I've talked to who would say it's an amazing drug. So I just wanted to let you guys know about that in case you have friends or if you have the disease yourself. Definitely advocate for knowing more about it. So. Yeah, Humira is a biologic. Any drug, there's different classes of drugs. There's chemo drugs, like methotrexate and things like that are very general. They work on an overall basis to decrease the production of cells that are produced, rapidly in the body. And that's why they can affect things like skin cells and hair cells. But blood cells, and especially the immune system, knocks it down a bit, enough to cure an overactive immune system. But the biologics are targeted molecules that specifically go after, deplete, and withdraw the attack of certain inflammatory chemical signals called cytokines in the body, in the immune system, that promote inflammation. And that's how they work. So they're usually proteins or groups of amino acids, which is what a protein is, groups of amino acids that are built together. They may be a big protein or a part of it that creates the signal that helps control the inflammation. So that's where the biosimilars come in, because they can look a lot like one or another too. And so that's why you can make a similar a medication to another if it has a very similar sort of functional aspect to it.
Dr. Anesi, can you speak to the second part of that patient's question or person's question on the potential long-term effects? That's something that doctors just aren't telling us about yet, and speak about the studies that were done, one that Dr. Foster did years ago, and then the replication that was done of that published in the British Journal.
Yeah, sorry, I didn't see the other part of that question. The long-term effects of these medications have been studied in a study that was called the SITE study years ago, and it's since been followed up by other studies looking at the long-term effects of biologics. In fact, it didn't just look at those, it looked at a lot of different medications. And it found that there was some potential comorbidities with these medications in the way of the way that they affect the immune system specifically. Anything that affects the immune system has the chance of increasing the chance of getting certain types of cancers later in life. Now, we don't harp on those because it's very unusual for that to ever happen. Your immune system is actually what keeps cancers from going on and from growing in the first place. So anything that decreases your immune capability has the potential to increase the chance of cancer, albeit very, very, very small. So we don't, like I said, ever really worry about it or almost ever see it. In fact, it's questionable that anybody's actually ever seen any of these medications lead directly to a cancer. But that's what the study had shown, a fraction of a percent possible higher chance. And there's some question of whether or not it was the medication or with the disease process that was being treated, because some of these autoimmune diseases also have increased chances of having, certain types of cancers and malignancies later in life. Very small, but, significantly or statistically significant, they call in the research. chances of having a higher. Now, again, it's not something we worry about or think about. It's always in the back of our mind. In the rare chance that we see it, I can't say that in 10 years I've really been convinced any medication we've given has ever caused this. So the medications are all extremely safe. They do far more good than bad. Any medication has side effects. Acetaminophen, Tylenol can kill you very easily, but people use it all every day, like it's candy almost. Sometimes people treat it like it's actually kind of scary how toxic it is. So, but any medication has the potential for good and the potential for bad, and the potential for good of these medications far exceeds the bad. And several studies have shown that it's been very, very safe. There's been other studies that the company specifically for adalimumab or Humira, the safety profile in several different studies looking at both uveitis and systemic diseases have shown it's extremely safe. The adverse effects are usually in like injection site reactions or sort of mild illnesses or something like that. Nothing really terrible. It's very unusual that anybody gets a very severe reaction to that type of thing.
Wasn't it the rheumatoid arthritis patients sort of skew the data because they have a high risk of lymphoma?
Yeah, like I said, like some of these systemic conditions actually already have a higher incidence of certain types of malignancies. So they don't really know if the data they're getting is due to the medication or due to the condition that's being treated. And it's so infrequent anyways, it's hard to really say. And I think that anybody who hides that much into the numbers and believes every little thing that they see for every study and think that that's going to happen 100% of the time is not, using enough insight into how life works anyways, because regardless of what the numbers say, things can always be a little different than that. And that's the way that I typically approach, medicine. We use that as a guide. It's not an absolute. It's something just to help us sort of think of what the realistic possibilities of what we're going to do will be later on. So there's another question down here. What is the bigger hurdle? Pharma companies not investing the time and money to conduct studies toward these drugs or FDA approval? It's more the first. And if you guys know anything about what it takes for a pharmaceutical company to get something approved for a condition, it's a tremendous amount of money and time. And that's if they're going to get any reasonable chance of approval. FDA approval is tough. It generally has a guideline, and the companies will set themselves up for success most of the time. And they're not ever going to actually do the study unless they have a high probability of having the medication be approved for what they want. So that's the bigger hurdle. It's just not worth it for these companies to necessarily get something approved for something that they're not going to make money on, first of all, or necessarily be able to even use. I mean, we're talking billions and billions of dollars that go into these approvals. It's very, very tough for them to get these things done. So
then insurance companies posing more stepladder mandates and prior auth requirements. That's the most frustrating part, I think, is the insurance companies, and you get something that's FDA approved, and then all of a sudden they want to listen to the stepladder approach to care. And I was just discussing this with Veronica, where they want you to start the non-FDA approved conventional chemotherapeutic over the biologic that is FDA approved, or they want you to be on steroids. And it's really frustrating because technically they should be allowing a patient to go directly to the biologic because that's the FDA approved one. So they use FDA approval to their advantage. If they don't want to cover it, they use a stepladder approach. And then, if it's not FDA approved, they use that as the excuse. So it's really frustrating, and that's where it comes back to us to write that medically necessary letter showing all the failures and the risk to the patient, which for us, we pretty much have like 90% approval on the appeals for the prior auths, but it is really frustrating. And the other thing that I find frustrating, and Dr. Anesi, you must find this even more frustrating, is when they decide which doctor can prescribe that drug.
Yeah, I'm just an eye doctor. What do I know?
The pharmacist is saying what's medically necessary. It's just infuriating, but nobody goes after them. I mean, I wish patients could band together and, you know, go after the insurance companies.
I've had a few choice words for insurance company personnel. There are other doctors and medical doctors that have been on the phone trying to reason back and forth with me whether or not something has a medical necessity. And when they really get under my skin, patients have heard me say a few things sort of in between lanes every once in a while. That's I don't usually get heated in the clinic, but that's one of the times when I do, is when I have to deal with them in the middle of the patient care area. So
Exactly.
if you're ever lucky enough.
I had one the other day that was calling for a peer-to-peer and we weren't available to do it. So we called back like 45 minutes later and the medical director said, or whoever was in charge of doing the peer-to-peers that day said, I gave you a 30-minute window to call back. And so I closed the case. But I was really excited to do it. I don't know anything about birdshot uveitis and those medications, but I did a lot of reading about it. I'm like, really? This is who you're putting forth to do a prior authorization on a patient? It's just very frustrating from our end to have an inexperienced person with no knowledge at all of the disease. And they're the ones making the medical decision, not your own doctor.
It's amazing that they actually call us out on those things, since we're actually one of the major sources of literature that they're trying to cite when they're telling us whether or not a medication is good or not for a disease state. You know, they're often looking up studies that we've produced. It's kind of funny.
Exactly. So it's challenging from our end to have to seriously do this with a person who's completely inexperienced. So I wonder if Veronica has any tips for patients and them advocating for themselves where, you know, you're in that situation where they're getting a medical doctor to do a peer-to-peer that has absolutely no knowledge of their disease. We get that all the time. Don't you agree, Dr. Neeson? We get like people that aren't even ophthalmologists doing, or not even ocular immunologists doing peer-to-peer.
No, it's true. Oftentimes they have a completely different specialty, but they work and they've been designated by the insurance company du jour to, you know, try to lecture me on what I should be doing for the patient that I've been seeing a long time. And they're not necessarily even familiar with the case, but then they look over and they missed a detail or something like that. There are some, I'm not going to dog all of them. Some of them are actually very much an advocate for what, you know, what the patient needs. And they actually try to make suggestions on how they can present it to whatever, or maybe they're hiding behind, you know, the fact that they're going to deny it by acting nice and say they're going to present it in a nice way. And then they act like the committee is going to deny it. Who knows? I'm not really sure. And nobody can be completely sure what goes on behind closed doors and paying for these medications. So,
yeah, I think from the patient perspective, this is where, you know, advocacy groups that are well aligned with a specific eye condition that you have, advocacy groups that are nonprofits, they may be foundations or associations, may have a really good handle or understanding of some of the challenges that are being shared today, and may have some patient-facing resources to help patients navigate some of these challenges. I think from my experience in the rare disease space is, we call it payer literacy, is something, you know, they use a lot of terminology that, you know, we as regular individuals may not understand. So sometimes advocacy groups may have, patient advocacy groups and organizations may have resources to help you navigate that frustrating process and challenge, and also get you some resources or tools to kind of just skill up to some of the knowledge and lingo, and also learn about some of the processes as far as, you know, getting a medication approved and some of the considerations for an infuse process as well. So patient advocacy groups may sometimes have resources for patients in that way.
Thank you very much, Veronica.
Yeah, that's a nice thing, actually. Let me comment on Horizon and other pharmaceutical companies that have gotten FDA approval for their ocular inflammatory products, is that they can offer their services in getting things approved. They've been great helps. There's not many of them out there that we are able to do this with, but there's a few. And any sort of service that the company can give, because it is FDA approved for whatever condition we're trying to treat, it makes the nurses' life so much easier, as well as everybody else, doctors and technicians, patients, everybody. So
there's some more questions in the chat.
Someone's asking about new studies on the Horizon. I don't think that means Horizon Therapeutics. I'm not sure. I think it's just new studies coming out, and there's definitely new medications that are being studied now for ocular inflammatory disease.
For any kind of rare eye disease or any rare disease, clinicaltrial.gov is always a good resource to find, but also communicating with your physician or your specialty team within the rare disease space. Sometimes people have conditions that they're co-managed by. So for example, patients with thyroid eye disease sometimes are co-managed by an endocrinologist and also an ophthalmologist or oculoplastic surgeon. So making sure that you're having that lines of communication open. But then also it's open domain information on clinicaltrials.gov as far as open and enrolling active clinical trial opportunities, but definitely have those conversations with your provider and your team as well.
Exactly. And on our website, uveitis.org, we have studies that we're involved with listed there as well. So feel free to go visit that site. It's a lot of information for you. And then someone else that looks like from Canada, but I also before that want to give a shout out, thank you to Jeanette for her kind words on being successful in getting her Humira treatment. And then there's a patient, Sue from Canada, and she talks about her struggles with trying to get Humira for her husband with posterior uveitis and having to actually go to a rheumatologist to get that approved and get a second opinion to get it approved after being on steroids. And that unfortunately still happens, which is what we were talking about. I think Dr. Anesi speaks about that or spoke about that in his talk about advocating and finding a doctor that's willing to prescribe the drugs that are appropriate for putting ocular inflammatory disease and other diseases like thyroid eye disease in remission. So maybe he can speak about that, being the advocate for yourself, finding the right doctor, the right specialist, and not settling.
Yeah. That's very hard to do, and it is something you need to do. It's not going to always be maybe the obvious choice. There are tales I've heard of people that should be reputable in uveitis care that frankly make me cringe about how things went. And then people come to us to solve the problem afterwards, and we do what we can. So you're not always going to have the best of luck going out to the next necessarily the uveitis specialist, but you can't let that sway you from trying. If somebody is sort of designated as a person who treats uveitis, you have to be open to what that person has to say. But one of the other sort of do's and don'ts, I guess more on the don't, was on list of that session that we had previously, was never just to listen to the MD, what they say, and take it all verbatim and everything's perfect. It has to make sense to you. I actually just said this to somebody yesterday. Like, I don't go into a room and just spit out a bunch of things and expect everybody to follow exactly what I say. I try to explain why I'm doing things the way, making recommendations that I make, and so that patients understand why I'm doing that. And I think that they have to make their own decisions, they being patients, about what they want to do based on my opinion of what should be done. It's not, I'm going to have you do this and that's it. That it should be a decision really we make together. The patients are responsible for their own care. That you got to you got to understand what's going on in order to be able to go forward with what you're doing. So now that comes into making a decision on which person to listen to. You know, go and find the uveitis specialist if you can. But if they're not making sense, or, you know, if they're just rattling off a bunch of commands to you, challenge them. Say, hey, why do you want me to do this? Why does that make sense to you? You know, and if they don't sit there and have the time to talk to you about something that may be very complex, I mean, we're asking you guys to take medications that cause toxicity, that have side effects, that all these things. They should be able to talk to you about all that stuff. And if they're not willing to do that, then they're not probably the person to treat you, to be honest. Because somebody who's thoughtful and mindful about your disease process should be able to sit there and explain to you exactly why. Now, keep in mind that they have a couple other patients to see. You know, you can't spend 3 hours with every person, but they should spend a reasonable amount of time talking to you about something that's serious enough to be able to, you know, go on to the next step of actually starting treatment.
Mm-hmm. And
I have a couple of patients who do take a little longer than needed every once in a while.
And I think with that is the patient bringing the information to the doctor. So we have a book that you can get on Amazon that's all about ocular inflammatory disease, the stepladder approach to care, and the medications that are out there for treatment. And so having that, or maybe just even getting articles on our website, we have all the publications that you can go to your specialist with and say, hey, like, I see that this and this and this is being prescribed now, and steroids are passe. I think having that information as the patient bringing to the doctor is important. And I know, Dr. Anesi, you spoke about that in your talk, with the patient being educated and advocating for this. We also, on our website, have many articles too. We have patient education articles, and there's a lot of knowledge to find there. We also have listing of specialists. They're not all patients that we train, all doctors that we train, but we do have the doctors that we train listed there. And we have those that have done ocular immunology training. So you can find on the list of specialists people there to reach out to if you're not satisfied with your specialist. Anyone else want to open up? We can open up discussion to other issues with orphan disease.
You can raise your hand.
We have another doctor online too, oddly enough, since he made himself perfectly obvious when it is up in the New York area. Dr. Swan, he was a fellow of ours, I don't know, 6 years ago, something like that. An excellent physician.
And he is also awesome at doing prayer health and appeals for his patient. He's very much an advocate. Hello there.
We see you hiding back there, Rob.
I couldn't not come. I'm glad to see how much you're doing.
Yeah, well, we appreciate that you've gone out and done the same thing and you're advocating for your patients. I know it's pretty frustrating. And recently you've been frustrated by the new guidelines they're putting in place on frequency and dosing.
Oh, it's
just infuriating.
Well, I just was told that I can't give Humira to one of my patients until I put them on oral prednisone, and it's actually going to be easier for them to get beyond oral prednisone for a few weeks. But the truth is, what's the plan? You know, like, I put you on 20 milligrams of prednisone. Good news, it worked until I stopped it. Like, what exactly were you? But exactly. I mean, you're not dealing with a sophisticated receiving end. It is, did you try prednisone? Please give me dose and date. And I said, well, okay, we're going to try prednisone. Exactly. And guess what? I don't think it's going to work, but they don't care. This was the dose. This was the date. Checkbox. Move on.
Exactly.
Yeah. Humira has gotten difficult.
It's a waste of time.
Correct.
They do the same thing though with Tepezza for the thyroid eye disease, and that doesn't work. But it's like all of them now are like mandatory. Did they try steroids? And
we do each of them try steroids. They all try it. Some of them, I'm not even sure that they actually took it, but I can tell you it didn't work.
When people ask me in a peer-to-peer about steroids, I definitely tell them directly that, you know, whether they've used them or not, if they have, great. If they haven't, I can say that they would certainly respond to it, but we would never keep them on it long term. And this disease process is highly likely to come back. So if you'd like to delay this person's care and put them at risk for getting worse, we can certainly try that, but that would be a fault of you guys. And I've said that to people countless times. And that seems to sort of resonate with some of them, not all of them. Some of them just don't have souls. But, you know, it does sort of maybe jar them into, okay, fine. You know, I know that I'm putting a Band-Aid on it for now and kicking the can down the road to the next person who you have to do a peer-to-peer with. You know, but I'm basically calling their bluff on, you know, yes, I know prednisone will work, but you and I both know that that's not proper long-term care here. So I don't know if that helps you at all, or that helps anybody else who's, you know, needed to get an authorization for their medication, but that's something I've done before.
I've been impressed that they've equated the steroid drops to the shot. So did you give them a shot or, you know, it's shot or oral or shot or drops, and then did you give them oral prednisone? But yeah, it's very frustrating.
It is frustrating. We have a question from someone about how do you go about actually getting a group together to stop the red tape at insurance companies? Maybe Veronica can speak to that. I know there's been a group out there that was having people sign on to try to do this. I think it's, it never actually went anywhere. But I think there are some foundations, if I'm not mistaken, that are sort of supporting this idea. Do you know?
So there are some advocacy groups that are focused from the, I'd like, not the insurance, but I like to say like policy piece and considerations to support patients and to advocate. And that's for the part where partnering with advocacy groups and understanding what is the best path collectively to advocate for challenges and barriers when it pertains to insurance and payers. So usually with our groups, we really let the advocacy groups do their magic and do their work that they're committed to do. But that's another piece of not just patient education, but also the policy and information and what you can do as a collective team and collective community, patient community, to work together with foundations that are relevant to your specific eye disease or vision specific groups in that way. So yeah, activating as a collective through advocacy channels is an option.
And the next one, I think, for you, Dr. Anesi, from Atlanta, somebody with uveitis on 3 separate occasions, no causes identified in workups, and no other known issues. How much should I be actively researching?
Well, you should always actively research if you have something significant like uveitis. The question I had when I saw that is, how often are you getting the flares? And people have different opinions on this. My is a little bit more aggressive. If you have a flare once a year or more often than that, then you should be on something long-term. I don't think that steroids once a year is okay. I think maybe every 2 years is okay. And depending on how severe it is the other question too. If you have severe disease at all, you should be on some sort of medication to help control those flares, because there are some types of uveitis that can cause you to have severe blinding, changes to your vision within days. And they're common too. That's not like a rare form of uveitis. Some of the more common types can actually do that. And so it is very important to recognize the severity and the frequency of your disease and get to somebody who knows what they're doing and advocate for long-term care that's not steroid dependent. That's what I would say personally. You can always come up to Boston if you want to come hang out with us, and I can talk to you about what your case is specifically.
RN and a certified case manager used to be working with insurance companies, is it possible to have one of the uveitis experts be a consultant with the insurance company? That would be awesome. I don't know. We've never been asked. I've invited insurance companies in. Years ago, I invited several insurance companies in to learn about uveitis and the medications that we use and what's involved in treating our patients, but we never got an invite to be a consultant, but yeah, we would love that. And AbbVie Patient Assistance is a huge company that cares about those of us who need biologics like Humira. When the insurance companies shoot us down and want us to try methotrexate first. Yeah, that's what we were speaking about earlier. Is so frustrating is they start with the stepladder approach to care that they never paid attention to before until Humira, the biologic, got FDA approval. So now all of a sudden they're following Dr. Foster's stepladder approach to care. And that's very frustrating, but you know, most of our patients do go through that stepladder approach to care. So most of them have had conventional chemotherapeutics, but one argument that I usually can make in patients in childbearing years is the fact that you might want to get pregnant on the medication, and Humira is safe for pregnancy and methotrexate is not. So that is something that usually can get the drug covered for the child rearing years. But yeah, it is frustrating when they're forcing a patient into a conventional chemotherapeutic when the biologic that can be safer is available. So that's where the patient advocacy, I think, comes in importance here. Do you have anything to add to that, Veronica or Dr. Anesi?
I just always say that an empowered patient, an educated patient is an empowered patient. So, you know, the more knowledge and information that you can obtain throughout your journey, and really having those open dialogues with your physician and your care team collectively is just a powerful journey and experience collectively. It's not just a one person's show and journey, but it's a collective team journey for sure.
There's a question about the cost of medications here, and I can't actually really give an educated answer about that, honestly. I think it's really expensive to make those medications, whether or not the companies try to recoup losses from them. I mean, Humira was created, what, 20 years ago, for, you know, the 9 or under the indications it was approved for before uveitis. So I don't think they're really working on recouping their the research losses anymore. But the medication itself is a protein. It's not cheap to make. So I think it's a bit, is probably going to be expensive. There's a lot of other drugs that are like that. You know, some of the injectables that we give into the eye for non-inflammatory conditions like macular degeneration and diabetes are also biologics technically. And those are expensive. So I think it's probably going to end up being expensive like it is to some degree. It's actually nice that it's not more expensive than what it is. But I mean, it's kind of what it is. Medical therapy now is getting so sophisticated. It reflects a bit of the cost that way, I think.
And they only have a 10-year patent, right? It's 10 years. That's it. So they're off patent.
That I don't know. And that's another push for these biosimilars. That's why they're trying to make those, because they are cheaper. The insurance companies, and it's not just the insurance companies, I'm sure it's Medicare too, that's really interested in having these, you know, medications be used because they are cheaper to produce. But I don't think that they work nearly as good. I mean, if they worked as well, I would say great. You know, the cheaper medication is always the one I try to use if it's just as, you know, efficacious, but they just don't seem to be that way. I've had really bad experiences with some of them for some of my patients, and I've been really turned off by the thought of using them. So anytime anybody tries to get me to switch over to it. It's ridiculous. I shoot them down in a second. If it's a new patient starting a medication for the first time, like let's say, like you have to be on infliximab, Remicade, and the insurance company wants them to start the other biosimilar, fine, but give that a shot first. If it doesn't work, then we'll use the new one. But sometimes they try to switch people, and Francis, you know this, from somebody's been on a medication for like 5 years, and all of a sudden they want to save a few bucks and switch to something different. That's a completely different molecule, and then then they have a reaction or they have inflammation. It's ridiculous. It's really just upsetting. So depends on the person.
The other thing is that from a perspective from buying it from our end, of course, we're not on the insurance pharmaceutical end. So I don't know what kind of deals Pfizer did with the insurance companies, because for us to buy Inflectra is more expensive than to buy Remicade. And Remicade dropped their price by $300 a vial or something when the biosimilars came out. So I can't really figure out what happened on the back end, but basically what happens is these companies come out and contract with insurance companies and say, you take my drug as a preferred drug and I'll give you such and such a discount. And that's why the insurance companies are now saying, oh, you got to use Inflectra instead of the Remicade. So they're not like thinking of the patient at all. They're thinking of their bottom line dollar, which I find even more frustrating. And I think back to the Celebrex versus, what was the other one? Was it Vioxx? There was a second drug. And
well, Vioxx, and there was Bioxin too, I think, back in the day.
Yeah, they forced everybody. So the Vioxx people came out and got a contract for preferred drug. Everybody was forced off, and then people were dropping dead of heart attacks. And the insurance company didn't take any liability in that situation at all. And that's what's frustrating, is they come down with these mandates. Oh, your drug's not medically necessary. Well, I didn't know a pharmacist could practice medicine. Sorry, but they don't take any responsibility for what the outcome is of the patient. It's very frustrating.
So Sue in Canada had this sort of long statement in the chat about Avastin or bevacizumab, which is a biologic-like injectable for other conditions like macular degeneration, diabetes, but it also works for macular edema for different conditions, including uveitis. And she was mentioning how that was used and how prednisone and all that stuff made her husband's eye worse. Well, the problem is the macular edema is being driven by an inflammatory problem, and Avastin does not control that problem. And prednisone, as you know, can help, but causes massive problems and masks uveitis and doesn't actually end up controlling the disease without severe complications and consequences on the side. So the Humira that she ended up using controls all of that stuff, drives, it helps to control the inflammation that's driving the macular edema and producing it. And that's why you're starting to get better. It may not be the be all end all, but it's definitely improvement from prednisone. So, you're welcome to come down to MERSI and have us look. If you're able to come down, we'd be happy to have you. But that's the type of approach that you need, something to help you get on a steroid independent method of treating the inflammation. And Avastin helps. I mean, I use it in acute, but it's never a crutch for uveitic macular edema. If you have persistent macular edema from uveitis, it means your disease is difficult to control or not yet under control most of the time. I think there's very few instances, in my personal opinion, of macular edema from uveitis when the uveitis is quote unquote quiet because of chronic damage. I think that there are people that think that a lot of the times, but I honestly think if the macular edema keeps coming back, it's usually because the uveitis is active to some degree and needs some other way to treat it. So.
And then Virginia also is asking about which insurance company is best for approving meds. It varies every year. They change their policies all the time. I know Medicare, typically any Medicare plan is very difficult because they use the FDA approval to their advantage. So those are usually the most difficult, but every plan each year comes out with a new policy, and with the biosimilars, we're finding them all being very strict with that and requiring those biosimilars to be used even on patients who are on a medication that's not the preferred medication. So none of them really at this point are, can I say, are great. But I can say you get what you pay for. So you get a plan that's the best plan in the insurance company, and usually it's the more costly plans. Those typically cover more than the lower level tiered plans. So you do get what you pay for in insurance, just like everything else. So I will say that I do absolutely notice that when we're trying to do these patient prior authorizations. Well, we got lots of thank yous, which we really appreciate. It's been great having everybody here. Anyone has any other questions for us? Any other, we can open it up to other topics. And that's nice. Someone commented that a lot of companies are now paying insurance in full to compete for talent. Very nice. We have a crash course coming up that is going to be starting off with a virtual September 18th. And you can go on ubis.org and find information about that. And then we will hopefully be live at Duke University in April this year for the full crash course. We have the auction coming up, Allison, which is going to be virtual on
November 6th.
November 6th, thank you. That's a great event for fundraising for the Foundation for Research, because I will say that it is the research out of our foundation, mostly our foundation and a few other facilities in the country that we use to get these medications approved. So we have to send in, because of the lack of FDA approval, we have to send in articles to support the need for the medication. And many of those come out of our foundation. So the money that we raise goes towards that research and also education. So the auction is a great way to contribute to help us with all we do in our mission of preventing blindness. And our support groups will be listed on the website. We'll have other support groups coming up starting, I think the next one is October 5th, but that'll be listed on the website. And we're going to
social media.
Say that again.
And as well on social media, we'll be listing the support group.
Oh yes, social media. We do have a Facebook site for parents, adults, and teens. And we also have some, we're transitioning our online format so that those other ones are not up and functional yet. But yeah, we do have places to reach out. And we have Pathfinders programs for our patients. That's a program where we set you up with someone with similar disease to get support. So a lot of good resources you can visit on ubis.org. And on the third dose of COVID, we are advocating for that. I've had mine already because I was 8 months out. So we're definitely advocating for the third dose of vaccine. Well, anyone else have anything? Otherwise, I think we'll bring our meeting to an end. We appreciate Dr. Swan joining us. It's been a real treat. Thank you, Dr. Anesi. Thank you, Veronica. That was a super treat to have you here. Any parting words for you, Veronica?
Thank you for having us